Hi, I'm Allie Ward, Editorial Director of Contagion. I'm here today with Dr. Paul Sachs, the Clinical Director of the HIV Program and Division of Infectious Diseases at Brigham and Women's Hospital, and Professor of Medicine at Harvard Medical School. Dr. Sachs, you're a longtime friend of Contagion. Thank you so much for joining us today to discuss COVID.
Thank you for inviting me.
First of all, how are you doing? Can you tell us a little bit about what your day-to-day has been like throughout the last couple months of quarantine?
Well, like all infectious disease specialists, our days have been pretty much consumed with COVID-19 and the response to it. Unlike some other specialties, before the surge happened in the United States, we were all kind of walking around with butterflies in our stomach. And then when it started happening, we, of course, were front and center in the response. And so managing that has been challenging and has been gratifying and has been frustrating all at the same time.
I'm sure. We're a few weeks out now from all of those, we're calling them remdesivir data dumps that came out. What are your thoughts on remdesivir as a potential therapeutic option for COVID?
So it's a very important question, and I should say that there were some data dumps, as you put it, but the most important data we haven't yet seen in full, which is the controlled trial, remdesivir versus no remdesivir in moderate to severe disease, that the announcement came from Tony Fauci and the National Institute of Health that they had decided to stop the study early because of a benefit that was seen in the remdesivir arm. Now, it was a modest benefit. It was a few days of more quick recovery, but if you think that there might be some people who respond better than others, that was enough for them to think it's worth stopping it. And I always have to remind people that it was a data safety monitoring board that made the decision, and they have access to all the data that we haven't seen yet. So there's that information still to come. I would say that there was a negative study from China that didn't accrue its full patient numbers because the incidence of disease stopped increasing in China. So it was actually good news that they couldn't accrue it, but still we didn't get full information. It ended up being a negative study. And then I will say that many of us are working at centers that have a lot of remdesivir treatment going on, and one gets sort of a clinical gestalt about the drug that is at least probably somewhat anecdotal, I confess, but it does seem to be helping some people, and especially if it started before they're too sick.
Right. And switching gears a little bit, the CDC recently put out a commentary on symptom-based strategies for discontinuing isolation for persons who had COVID. One of the things that was mentioned in the commentary was that as of its writing, replication-competent virus had not been successfully cultured more than 9 days after the onset of the illness. Can you kind of walk us through that finding and explain what the significance there is?
Yeah, well, one of the key challenges with COVID-19 recovery is that certain individuals, for whatever reason, continue to test positive with a positive RT-PCR with a positive PCR of the nasopharyngeal swab for a long time, even after they've completely recovered. And that includes not just people who were seriously ill, but also people who had moderate or mild illness. And so those people who have persistently positive tests for a long time, there's a debate among us infectious disease doctors and among epidemiologists is, are those people capable of spreading the virus onto others? And it's really not known. So what CDC tried to do is it tried to take those persistently positive cases and see if they could get replication-competent virus, and they were unable to do so. So I always look for good news in everything. And so let me try to find some good news in this. It's possible that what these PCR tests are detecting is just fragments of virus rather than actual virus that can be transmitted to other people. Now, it doesn't change healthcare systems making recommendations like they want people to test negative before returning to work. That's certainly very common at most hospitals now, and I understand that. But at least gives us some hope that some of these persistently positive tests don't represent actual contagiousness. So I got to use the title of the magazine in my response.
Bonus points there. Throughout this pandemic, we've just been receiving and consuming information at breakneck pace, right? A lot of that is due to the way that data are being released and interpreted, what with preprints and non-peer review articles getting out and picked up by the mainstream media. What is your take on how this COVID-19 pandemic has affected the flow of scientific literature?
Well, the flow of scientific information has been, massive, and everyone uses the same analogy, which is trying to drink from a fire hose. But I get tired of using the same analogies. So I was having a conversation with one of the best, I think, science reporters out there, Helen Branswell, and she's Canadian. So she said, I don't want to use that metaphor. I said, well, what? She says, it's like Niagara Falls. That's Canadian American. I said, it's like trying to get a glass of water from Niagara Falls. I mean, that's what it feels like sometimes. So on the plus side, it means that the information is being shared very rapidly. On the minus side, it means that non-peer-reviewed information, some of it probably false, is getting out there and can be seized upon. Nonetheless, I mean, there have been some very important reports that have come out of preprints, and one of the early ones was about asymptomatic viral shedding in people in Germany, and that ended up being quite important for our understanding of how to protect people going forward. So, it's not an all or nothing thing. One thing I do wish is that now that we have this remdesivir treatment signal on our radars, that becomes quickly a standard of care that we can give to people, so that other interventions can be piggybacked on top of that. So it's not just remdesivir or nothing, because it's clearly not going to be only remdesivir that's going to get us out of this sometimes very serious disease.
Definitely, that's a good point. We're by no means out of the woods here. We're just at the very beginning, but what do you hope that the infectious disease community of clinicians can kind of take away from dealing with this pandemic experience?
One major thing is to recognize the primacy of public health in protection of our society. Paying for public health isn't popular because when it does its job well, it's completely silent and in the background. But all one has to do is look at the state we're in right now in the United States, leading the world with new cases, deaths related to it, and realize that lacking a strong public health infrastructure has really put us behind in managing this huge outbreak. It's ironic that the countries that actually experienced SARS, in particular in Asia, were much better prepared for this than we were. So if you want to look at a sort of textbook example, you'd look at Taiwan. And Taiwan, of course, experienced SARS, and so they set up this response to what they assumed would be another pandemic. And they were so well prepared that they really have not had much of an outbreak there at all. And then there have been some other shining lights, Singapore, South Korea. I mean, as soon as something starts to flare up, they move in, test, and isolate and get it under control. We have not yet been able to do that. So I think that's one message that we infectious disease doctors have to sort of state loud and clear, that the public health response, public health infrastructure has to be really sustained. And one other one, which is more personal, is that the way that healthcare is delivered in this country is predominantly based on procedures and healthcare is financed, is predominantly based on procedures and based on doing things rapidly. And neither one of those things is something that infectious disease doctors do. We're very careful in our deliberations and our assessments, and we don't do any procedures at all. And as a result, we kind of have been undervalued in the American healthcare system. And I hope that this corrects that, because if anything brings up the importance of infectious disease specialists, it's a global outbreak like this.
Absolutely. And you sort of answered my next question in the answer about public health preparedness, but do you see any other long-term effects of this on the healthcare system in general, whether it's an increased reliance or emphasis on telemedicine or having those infrastructures in place?
Yeah, there's really, it's going to be totally transformative. And it ended up being one of these things that developed quickly because it had to. When we realized that people didn't want to come to the hospital for their outpatient visits, and they still needed to communicate with their clinicians, then telemedicine suddenly became available. And now we have to convince the payers that it's worth paying for. And if not, then they're really not responding to the current needs of the patients who need healthcare. So that's one thing. Other things that have to change, we can't have crowded waiting rooms anymore. That's really not safe. We can't have people who are sick mingling with people who aren't sick in those waiting rooms. We have to rethink our use of masks in public for now, and that's something that, a lot of us were wrong. I mean, we didn't think that masks were going to be helpful in preventing the spread of this virus, but it turns out that yes, since there are people who are asymptomatic and shed this virus, that wearing masks for those people probably does prevent spreading the virus. So all kinds of things are going to change. I don't think we're ever going to go back to the way it was pre-COVID-19 100%. I do hope that there will be a diminution in the number of new cases and we'll have some partial return, but it's not going to happen quickly. This is, another overused metaphor. This is going to be a marathon and not a sprint.
Absolutely. Dr. Sachs, is there anything else that you would like to add?
I think that maybe that last message that people shouldn't lose hope, but they also shouldn't expect things just to immediately be back to the way they were. It's unrealistic to expect us to suddenly go back to before we had SARS-CoV-2 circulating in our community, because that virus, while predominantly dangerous to the elderly and people with comorbidities, can occasionally cause very severe disease in young people too, and we have to be aware of that fact and not move too quickly.
Definitely. Dr. Paul Sachs, thank you again for joining us today, and thank you so much for the work that you're doing.
Thanks for inviting me. It was nice chatting with you, Alexandra.